next, Dr. Angela Hardwick, who is one of our Ohio Health Movement Disorder physicians. She is our deep brain stimulation guru, and I'm going to turn it over to her because I'll mess it up. So come on up.
Good afternoon. So I haven't been here as long as Dr. Hinkle, but I am here partially because he called to recruit me to join him to help out. I feel like it's a little echoey. Do I need to step away? Okay, fine. All right, so I have a few slides. I'm just going to tell you a little bit about deep brain stimulation surgery. I know there's a couple people in here who have actually gone through the process, and so afterwards, if you want to reach out to some of them, they usually nicely identify themselves very easily. All right, go ahead, next one. Or do I hit a button? Do I hit the button? Oh, there's a thing. All right, there we go. All right, so when you're considering DBS, it really has the big thing is, are you a good candidate and what are your goals? So you gotta have regular Parkinson's, and that's where the whole idiopathic piece comes from. There's a lot of the Parkinsonism patients. I meet a lot of them and they want to have this procedure done, and I honestly tell them, I can't guarantee anything. And so it's not the best idea for them. You need to have at least 5 years of symptoms. Something about 5 years is really special because I think any movement disorder physician that you meet will tell you that someone walks into your clinic and you think, yep, this is exactly what they have, and then things start to change. So that 5 year really makes us sure and comfortable and confident that we've got the right diagnosis. Patients who are interested in this really got to have a good response to medicine, because at the end of the day, DBS will mimic, we hope, how the medicine does. So if you take pills and it doesn't do anything, well, it's not fair to expect DBS to do things that medication can't do. Reasonable goals, I have a whole slide on that at the end because it's super important to me. Age less than 85. That's usually kind of surgeon-driven. I think my surgeon, if I were to present to him someone that was like 87, I would really have to bribe him and beg him. But just because after 85, they don't want to do surgeries generally. It's just about safety and making sure that you're a good candidate and something else won't be the issue. Minimum symptoms of hallucinations and dementia. So if we know that someone has difficulty with Parkinson's, and then additionally, we're having this additional battle of dementia and hallucinations. I mean, it's one thing if it happens on a certain med, but if it's a constant battle, this might not be the best thing to introduce instrumentation. Okay. And good family and social support. Our navigator is here today, Jerry Sesko, who helps families go through this process of being evaluated for DBS, the day of surgery, and then some of the aftercare things. And if you don't have family to get you to appointments, family to get you to surgery, help you out afterwards, it's tough. And so we find that the people who do the best are those who have good social support and family. All right. Now, what do we have to do to get evaluated? And so it starts with after you meet with your neurologist. Most people will refer them to, within our group, either Dr. Patel or myself. And we go over the things that was on that first slide. How long have you had it? Do you have good family support? How much medicine you taken? Is it working? Such, 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 such. Then I'll send you to go see the therapy team, which you've met a lot of them today. And their big thing is, how are you doing before surgery? And are you the best you can be? And are you as tuned up as needed? If you have any trouble with swallowing, we need to work on that before surgery. If you have trouble walking, we should work on that before surgery. Let's just make sure we are presenting the best version of you possible for surgery so that it's successful. They also do a lot of scales. And I don't know if you go see your doctor and they're doing this thing. Yeah. And so it gives us a number, and we look at that number on meds, we look at that number off medication, and we compare the two, and some of that is insurance, some of that is what we need for our data compilation when we're meeting as a group. But that's why you have to go to therapy that one day and go through that whole process. Neuropsychological evaluation, I tell patients that's kind of like finals week on steroids because it's 3 hours about where they're really making sure your mood and memory are strong enough to go through this procedure. Like as I said, we don't want trouble with memory. That's out of line with what we would expect for somebody of the whatever age group you present in and whatever and within the Parkinson realm. Brain imaging. So sometimes this is done before you meet the surgeon, and sometimes this is done after. The surgeon will do this MRI of your brain, at least at Ohio Health, asleep, because he uses that so that he can determine and navigate where is he going to place the leads needed to work, and so that we can avoid structures that we don't want to have damaged. And so that's where you also need the family support to get you to and from MRI, to all these appointments, especially that MRI because you're put asleep for that. And then there's the neurosurgery evaluation. So with our group, that happens after we have a big committee group. And so we really try to gather all the data and then present it to the neurosurgery department and to say, this lovely patient has had this for at least 5 years. This is how much medicine they're taking. This is how well they're doing on that scale, on and off medication. The navigators there are talking about all their family support. Is there anything else you want to know before you say yes? That kind of a thing. So we're often the biggest cheerleaders of you to the neurosurgery department to have the procedure completed. All right, so where and how? Well, there's 3 targets. And so which target we pick and really depends on what your goals are and what the problem is. So there's one target that's beautiful for tremor. There's another target that's really good for medication reduction. Another target great for dystonia and cramping. And then there's targets that just kind of touch a little of everything. So we really talk about that in the meeting and in the committee and as a group to come up with a plan. It can be awake or asleep. And hearing about some of the patients that have come up here today, some people were done asleep, some people have done awake. It's a changing and evolving process, I will tell you. So I've been doing this about 10 years. And when I started, I will tell you, almost everybody did it awake. And things are starting to change. And yeah, more places are starting to do it a little bit asleep. So it really just depends on where you have it done and about the person themselves and which target, all right? And then, so not only do people get the leads placed, they also come back in a couple weeks and get a battery placed in the chest. And so I get a lot of patients who are actually surprised by this. They really focus on, okay, it's a surgery, it's awake, and then I have to come back to get a battery placed, and yeah. And so the surgeon, when you meet them, they'll talk to you about which side, which is important if you have a spouse that lays on one side or the other, or if I'm a right arm purse lady. So which side would you want it on? Do you have enough meat up here to put a battery? Or do we need to find some other spots on the body to place the lead, okay? And so there's a lot that goes into how this all gets in and where. All right, now, why would you have surgery? And so this is the biggest thing. It's really about the goal. And so when patients come to me and they say, I want to have DBS because I want to live longer, I want to run, I want to drive, I want a needle point, I want to be a dentist again. These are real things that patients have come to me and said, this is what I want surgery to do. And I have to tell them, I don't think you're going to be too happy. You're going to not like me when it's over. Reasonable things that I believe that we can usually give patients are tremor, stiffness, slowness. It's great for that. It does a really, really good job. It actually sometimes can worsen walking, could worsen speech or swallow, which is why we really try to tune those things up first. And I don't hide those things. I really tell the patients when they come to see us, and Dr. Patel, and we see patients, we tell them, this is what it is and isn't going to do, so that you're not surprised afterwards. And it's very interesting because when patients come back after having the leads placed and we start getting them some benefit, they then kind of want, what can you get this to? And what about this? And then I say, well, wait a minute, you still have, the disease is still there. We globally say, think about 60-70% improvement. Or for some people, it's hard to conceptualize, what does that look like? And some of the data suggests, roll back 5 years. Well, 5 years ago, were you taking medicine? 5 years ago, Are you still requiring a little bit of assistance with like buttons and things like that? Then after surgery, you may still need that. It's an awesome tool. It does a lot of great benefit for our patients, but goals need to really be discussed. And so when you meet me or Dr. Patel, if your neurologist decides that this is something, a road that you're going to go down, we focus on goals a lot, okay? Just so that you're not like disillusioned or upset about how things go afterwards. Dyskinesia, it can do a great job for that. And sometimes I can reduce the amount of medication, sometimes. I think in my career of 10 years, I have had 5 people come off meds, 5. I've been to hundreds of procedures. I trained in Florida with Oaken, which I saw on someone else's slide, and we would go to surgery, 2 patients every single week, 5, okay? And so, say that again. Wait, I'm having a hard time catching the end of the 5 who got off medicine. It was temporary. It didn't last forever, because I say, if you think your clock rolls back by 5 years, that clock keeps rolling. And eventually, it will get to the point where medicine is needed to help with the device and to help the DBS continue to help the person have the best quality of life. All right, and so I think DBS is an awesome tool. That's why I actually stayed in neurology, and I don't know if Hinkle knows that about me. I almost left. I honestly almost left neurology, and then I got to see a DBS case. And I was like, whoa, this is why I'm here. This is why I signed up for neurology and not primary care or something like that. It's an awesome and can be a life-changing device and procedure in the right patient. And that's it.